Thank you. Thank you, Sanjay. I think it was great to witness it for the first time. See, is there any chance the tip of the catheter, such a long one, getting into renal vein or some other side branch? Because we are not putting it over the guide wire, it is through the sheath. Can it take a wrong route anywhere?
You
What
should
we
do it
can
over the
do,
guide
sir,
wire.
yeah, well, see, there are, see, what I did is I removed the guide wire and then pushed it through the peel away sheath. If you are so worried, we can always leave the guide wire and peel away sheath, and through that we can bring it out. Shouldn't be a problem.
And Dr. Anil,
What is the length of this catheter?
So 55 centimeters.
55. Okay.
and the guide wire you use, it looked black. Is it glide wire, the thermo wire, or the regular
Yes, sir. It's a glide wire. No, sir. It's a glide wire.
glide wire?
Yeah, it's a glide wire.
So for this catheter 55, I think this is just a regular tunnel dialysis catheter, correct?
No, sir. 55 centimeters we don't
Use regular
use
catheter.
except for transfemoral or for this one. Majority will be around 23 to 27 is what we
No,
use.
I'm trying. No, what I'm asking is, this is a tunnel dialysis catheter, but it's a little longer. You said it's 55. Is that correct?
Yes, sir.
Yes. I
Yes,
see.
sir.
Okay.
It's a longer. It is a similar catheter, only a longer catheter.
Okay.
It's Adrian.
Yeah. Dr. Sanjay, thank you very much.
Took off 50 and then 5 centimeters for the cuff length, and so.
Right.
Dr.
Dr.
Rajendra,
Sanjay, yeah, go ahead.
Dr. Rajendran, you want to add something? Yeah.
Yes, sir. I must say this is commendable that he was able to do this many cases. I've been doing dialysis work for 20 years. Like I would say that I've done less than 10 cases. It's a reason because that most of these patients don't fit the criteria. By the time they come to us, even the IVC was gone. So we end up doing like transhepatic, and like most of the times we are successful in recanalizing the chronically occluded veins. So it's like, that's this one. So I have a couple of things to add on, like, so he mentioned about like IVC stenosis and thrombosis is very unusual. Especially I've seen with some of these patients who had a chronic femoral lines going into the right atrium, the catheter that long. If you see the IVC, the narrowest portion of the IVC is actually the hepatic segment actually of the IVC, which is right around where the caudate lobe is. So that segment is, even if you see in the CAT scans, it's like a flat, this one's like, so that area gets stenotic on a long term in terms of either transfemoral or translumbar approach, so that is probably the only thing I want to add. And I have a couple of questions to ask, so I noticed that the peel away sheath doesn't have a valve on it. Like, does all your catheters have similar peel away sheaths which doesn't have a valve?
No, sir. Nowadays we use only valved peel away sheath, but unfortunately the Medcom doesn't have a valve.
Okay. Yeah, it's just this one actually, And then I want to add one more contraindication, like, is that, like, especially in a chronically bedridden patients, there's a lot of bed sores on the back. So we try not to do those translumbar access in these kind of patients, like, so that's probably one contraindication that came to my mind. I also have one other question, like, so it's actually a very good data. It's actually, in fact, it's better than some of the data that's reported in the literature, actually. So it's, I just curious about how many patients you actually follow. Like, you did 30 patients, and you presented the data in terms of percentage on like how many actually survived, but I just don't know what the number is.
No, as I told, sir, 30 patients underwent the procedure. Out of which 2 died post-procedure, 1 died 24 hours later, and the rest of the data is based on these 27 patients.
Oh, okay. So it's data is based on most of the patients that you've done the procedure on.
Yeah.
Okay. Oh, yeah. I must say, Dr. Sanjay, this is a very good job. Actually, given the limited resources that you had, this is excellent. And I also wanted to emphasize the point. I think we talked about it last time too. Is that when you're using the needles, like the difference between what IR does, even here, like what the IR does and what the nephrologist and others does in the ICU setting is that. So we use a micropuncture needle. What it means is basically it's a 20 gauge needle. I just tell our residents you can put a 20 gauge needle anywhere in the body and you can get away with it. Is a 20 gauge needles like we have a Chiba needle that's 15 centimeter long. You can even have 20 centimeter long, and it comes with what they call a transitional dilator. It's a 3-part system. That's actually a lot safer than using this 18 gauge stroke heart needles. So it's okay for this because there's not many critical structures on the way, but you're doing like occluded segments of in the neck. It's safer to use a smaller needles.
Point well taken.
Thank you, Dr. Rajendran. I agree with that. So this is Anil Agarwal from California. So first of all, Dr. Sanjay, wonderful presentation. You really covered everything, and this was very comprehensive. Great work, and keep it up. I have a few things. One is to Dr. Rajendran. Actually, interventional nephrologists in US also use micropuncture needles, but the practice does vary. Some may not be using, but I always used my micropuncture needles. The other thing is in response to Adrian's question about the length of catheter. So I think because there is such a long tunnel coming anteriorly, you need a longer catheter. The only question I have for Dr. Sanjay is, you really don't need to put the tip into the right atrium? Because when we started doing even the femoral catheters a long time ago, we were using the long catheter going all the way up to right atrium. The problem is if you cause thrombosis, it thromboses pretty much everything. So we started putting it around L2 or so. So you could potentially use a slightly small, less lengthy catheter, although you can use it for the tunneling. And one other thing I have is, could you elaborate on the cause of death in those 3 patients, 2 being immediate and 1 in 24 hours? Thank you.
Yes, sir. Thanks, sir. Thanks for the kind words and the point well taken. And the cause of as I told you, sir, the patient who was, these 2 patients, when they came to us, they were severely acidotic in fluid overload state, and very poor, inadequately dialyzed, and had hyperkalemia. So whatever measures we had taken, it was not responding. So only thing was to put an access and immediately take up for dialysis. We put the access, but same, we did it in the left lateral position. We could not put them in the prone position also. But immediately after the catheter, the patient had arrest. I'm not saying that it was, the cardiac arrest. It was basically the respiratory arrest which led on to the cardiac arrest. We wanted to intubate. We intubated the patient, but again he went into cardiac arrest.
Okay, thank you very much. No complications from the procedure.
Apart from these 3, I have not found any complications. Even removal of the catheter for those who we could create a fistula later, and those who went in for a transplant. Usually people are worried about the IVC bleed. No, it doesn't happen because of the negative pressure which is created on the IVC as it is in the retroperitoneal space. I have not found bleeding to happen.
Thank you.
Yes.
Dr. Suresh?
I just want to add one more. Sorry. So we work with a lot of IVC other than these ones. It's a misnomer to think that you puncture the IVC, it bleeds a lot. I've literally ruptured IVCs and it doesn't bleed as much as you think, on the contrary to everybody's belief. So you can puncture the IVC with very big needles, still it doesn't have a lot of bleeding.
And one more point I wanted to put in is, whenever we put the dilator or we did the sheath in and pull the dilator out, we never found the bleeding to be profuse in IVC cannulation. somehow I don't know what is the reason, though we feel that the pressure must be high, you will get huge bleeding, but it never happened.
The
So
pressure
when
is
we take
usually about pressure is about 2 to 4 millimeters of mercury. It's not that high. It's less than the right atrium.
So when we take out these catheters, I understand that you're saying the pressure is low and the chance of bleeding is less. But do you have to keep them supine, flat on their back to prevent any bleeding, or they can just continue without any, precautions? Once you take out the catheter.
No, initially we were little very skeptical taking out the catheter, keeping them under close observation and trying to do ultrasound to find out whether there is a bleed or not. But after one or two patients, now we were very sure that nothing is going to happen. But what I do is I keep them in the hospital for at least 12 hours observation before I discharge them.
But they'll be lying on their back?
Yeah, they'll be lying on their back.
Okay, that's what I wanted to hear. Yeah. Great presentation, by the way. In hospital, once they come to this stage, we can't do anything. We have good guys who can do something. So we always tend to refer to them. But great presentation. I want to say I learned a lot.
Okay, thank you.
Okay. Any other variations in the technique or any suggestions by anybody else?
Basically, few things. Is an excellent presentation and it's amazing. From my experience, as I said before, being in the university program, we get patients who have been out of accesses from the community. So as Dr. Rajendran said about contraindications, most of the time we don't care about contraindications because you have to provide them access. So it doesn't matter. We just did it. We started doing this from 2000, and we in the university have done a lot of catheters until I left there. Most of the time we did in a semi-prone position because they, as Dr. Sanjay said, they cannot lie on the tummy. And the important thing is to keep the entry point below the level of the renal vein. Basically, you have to keep it to the level of the L2, L3 so that you don't transect through the junction of renal vein with the IVC. And I always did with over the wire, so that especially in those days when I used to do, it was the catheters were split catheters. The ash catheters was a commonly available tunnel catheters with 55 centimeter length. And so when you put the catheter through the peel away sheath, being split, it can get into one of the side branches, and then it becomes a nightmare fiddling with it. So we always did it with over the wire and glide wires. And the exchange, many of them have to have exchanges done because of tunnel infections and the catheter not working. It's a little bit challenging to do the exchanges because you have to be quick and can have some bleeding because they already form a tunnel and they can bleed. But the bleeding complications are not that common. The only time I've seen retroperitoneal hematoma done by vascular surgeon who one time seeing us putting these catheters, tried to do it and ended up with this huge retroperitoneal hematoma and ended up with a cardiac arrest because I punctured the aorta. So you have to be careful not to cross a midline. That's a good point because you don't want to fiddle. And many of these people's coagulation profiles are not good. And with a high-risk patient we have in the United States, there's huge morbidly obese people. So hitting the aorta is a problem. So other than that, it's relatively, if you are careful, it's rewarding for the patient to give some longevity of life because all of them at the end of the life, there is no question of getting transplant in this patient in our population because this is the end of life accesses. But of late, I don't think I've seen many. I've not done this for the past 2-3 years, and the number of patients getting these procedures have gone a lot less because of the advent of hero accesses, hero grafts, and with the current surfacer technologies and all that stuff. There's not much utility of these access, even though it is in the armamentarium. And the transhepatic, that's a brutal procedure. It doesn't work. Most of the time, you don't get good flow. So this is a good thing to know, to do it, where you can it's a salvage procedure for these patients and provide some longevity for these patients to get more dialysis when all the accesses are run out. So that's my point on these patients.
Yes, thank you. There are some questions in the chat box. Karthik, can you unmute Manish? He wants to know, is there any chance of lumbar vein injury by Pilave sheath? One, have you used two guide wire method?
No. I have not used two guide wire method. I told you there are two guide wires. One is to just to get an idea of what is the length of the catheter and where should be the exit point. So I have not used two guide wire technique in this. And the chances of lumbar vein puncture is there, but you know, when you know where you are going, as sir was saying, you should not go beyond L2, L3. So your idea should be to be below the renal vein. So usually when you are there, the lumbar vein chances puncture, and if you are going anterior to the vertebral body, as I told you, when in that position, usually the IVC falls forward. So you have to be anterior to the vertebra. So in that case, usually the lumbar vein punches are less likely.
Yeah. Manish mentioned about this two guide wires, to avoid sheath. Manish, are you there? Okay. So he thought putting in two guide wires and putting the catheter over the guide wire and not across the sheath. You are not thought of it.
No, I
Right.
have not done it, sir, but now we have started doing it for the other pump cats also. So that the sheath, when you put, usually you should not go till the vein, because you will get a larger tear.
Yes, yes, yes.
So that is the reason it is better to have a double guide wire and do it.
But
I
again,
believe that
you mentioned that the path is quite direct, unlike left-sided jugular.
yes, yes, yes.
Yeah,
Yes,
so
sir.
I think there may not be a big issue using the Pilave sheath. Okay. I think other questions have been answered. Thank you, Dr. Sanjay, and all the panelists. And I think I'll share one small tip for in AV fistula area. I think we have some time. Yes. Yeah. So AV fistulas, I keep doing AV fistulas side to side, and I tie the distal end and cut the distal end of the vein after tying it. And people used to ask me, what is the advantage? You could have as well done a end to side to the artery, vein to the artery. So here I want to demonstrate how it has helped me in certain times. So I don't know whether the picture is clear. So what you see here is the artery, and this is the vein. And so this patient, after the finish of the anastomosis and tying the distal end and cutting it off, somehow the flow wasn't adequate. There was a valve somewhere here, and maybe one of the sutures caught hold of the valve, or sometimes there can be some obstruction in the flow of the vein. So if the flow is not adequate, what I do is I cut open or reopen the distal end and put in I try putting in a feeding tube, and sometimes feeding tube also may not go across some obstruction. Then I try with a small dilator, which comes with your central vein CVP catheter kit, and that way I have mended quite a number of them, because it is much better than reopening the anastomosis and redoing it, which at the end of 1 hour, I think we won't have the energy or the mood to do. So to make it diagrammatically, so this is the vein and the artery. So I make a side-to-side anastomosis. Not all the time you have such approximating vessels, but you can bring it from farther. and do the anastomosis. And by tying it and cutting it, what happens? This one advantage is the vein, there is no traction in the artery. Once you cut this, it gently lies on the belly of the artery. And many a times I make the incision in the vein in the posterior aspect and the artery in the anterior aspect if they are, if they are brought from some distance. And once you do this tying and cutting, the traction in the vein goes off and it gently lies, and there is no jet effect in the vein. So that was one advantage I used to think, and I always do this. And if you feel there is you have to redo or you'll have to recheck the flow, then I take off this or make a cut here and then introduce a feeding tube or a dilator and mend the thing and then try it again. So that way I have been able to salvage some of these patients. And this is to answer why I persist with the side to side and tying and cutting the distal. Any comments from people who do AVFs in the audience?
That is amazing.
Keep asking. You can as well do a end to side. Why do this? That was the question asked to me repeatedly, and I never had time to explain to them these two advantages. Yes, Girish.
Yeah. Shahbaz, yes, Abbala sir. So, yeah. So while constructing the fistula, what I do is simply after venotomy, I put the infant feeding tube and move it proximally so that during anastomosis it's much easier, so that those two walls do not come close together. So that makes even the simpler work much simpler. So the problem that you said that there might be some vein or anything else, so that can be overcome even before. So I always put a feeding tube through the vein, and it gives me good space to work with also, so that both the layers do not come close together, and that helps me out. That's how I do it. Otherwise, the rest of the procedure that, I do cut after doing side-to-side anastomosis, I'll cut the vein distally so that there's no traction over the vein. So that is the way I work.
Okay, yeah. Anybody? Okay. And then
Dr. Bala, it's amazing. It's good. I try. Most of my patients, I can't get side to side because the veins are so far away.
Yeah, that's again.
I don't know why I'm so lucky. So I have to mobilize the vein and end up doing instead. But basically, your technique, this is basically you're doing a valve. Most of them have valves there. When you pass that and you take care of the valve, and it helps to open up the vein. So it's good. It's amazing. You could do it. This is the best anastomosis when you can get the side to side more than the end to side. It gives longevity, especially for radiocephalic fistula.
And cutting the distal and makes it that they call it piggyback. When you have the arterial incision in the
piggyback, P-slot. Dr. Shenoy always talks about it.
He keeps telling that phrase. So you take the arterial incision in the anterior wall and the venous incision in the posterior wall. So it lies over the artery. Then
the turbulence is less. You don't get much turbulence in the juxta-anastomosis part, and you don't get stenosis in those people.
Yes.
So.
Okay.
Last week I was doing a surgery, and the vein was so far away. I have to tunnel it to get it to the artery, and anastomosis the interstitial. It's good if you can do this all the time.
Yeah, that's another idea, right? Okay. And in the discussion group, there was a question raised by Dr. Arun Verghese about the difficulty or doubts he had while trying to do biopsy in a patient who had 3 transplants. Arun, are you around? Arun Verghese? Okay. This is the the CT thing here. Karthik, if Arun is there, unmute him.
check, sir.
Is he there, Arun Varghese?
Sir is not here. What are we looking for, Bala?
See, he raised a question that he has a patient with 3 kidneys. I mean, 2 transplant and the 3rd transplant, and he wanted to know how safe or how best he can do a renal biopsy in that. I didn't exactly get what he wanted. So, and there were some answers, and some people thought, what is the issue? Anyway, you are doing it ultrasound guided. So, I actually invited him to put forth his doubts in the forum today. And he has sent this CT, but unfortunately, I don't find him in the audience. Karthik is not there. Okay, even if he's not there.
Yes, sir. Sir is not here.
Okay. Any of you foresee any problems when there are multiple transplanted person for biopsy? Okay. Right, I'll stop here. Right then. So I think then is Dr. Suhas here? Dr. Suhas Bavikar? Yeah, okay, he's also, because when I announced this topic, he had sort of put forth this apprehension that we are guiding youngsters, to do more complicated stuffs and dragging them away from AV fistula by making them do more and more venous catheters, etc. So I thought he can. And there were many other voices. They said, "No, this is order of the day, and we can't escape accessing the central veins." Okay. And I think if there aren't anybody else want to share any issues or questions from the audience, Karthik, you can unmute everybody. Okay.
Sir, good evening, sir. Just wanted everyone's blessings. Monday we'll be doing our first case in the cath lab.
So your own cath lab, right?
Yes, sir.
What is the apparatus they have given to you? Flatbed or mobile?
No, sir. It's a hybrid cath lab, sir. So the operating table can be completely detached from the SIA. So it's a new fully loaded hybrid cath lab.
Fantastic. I
You
think
should
Congratulations.
send us some pictures. Send us some pictures, Girish.
Thank you, Shahbaz. Thank you, sir.
Good luck. Good day.
Right. Okay.
Sir.
Yes, Sanjay.
Sanjay speaking, sir. Sir, I just want to put forward, I had attended the last workshop of Avatar for intravascular procedures, and I did my first procedure around 10 days back. Very happy that I could do venoplasty for radiocephalic, which had a block up. And to my surprise, there was one more accessory vein which was going down. And I remembered you that you could tie it from the above, but I made a nick, took the thing, and I closed it. The fistula is doing very well now. And I thank Avatar for having given me an opportunity, to go into this part of intervention which I was not doing.
Actually, last week I did a coiling for a deep accessory vein. I think I will show it sometime in the future. Okay. Right then, I think for once we are finishing well in time.
Yes, sir.
I think we'll stop. Girish, anything else?
Yes, sir.
Thank you.
Sir. Thank you so much.
Anil, Dr. Anil, Adrian, Suresh, Rajendran, and I think we'll meet next month.
Sure. Thank you so
All
much,
right.
Bala
Good
sir.
night, everyone. Good
And,
night.
and I think this society has been started, and the next Avatar India, that will be the first meeting of the society, is being hosted by Sanjay, Girish, and team in Bangalore. So let's all look forward. Just a lot of time, and this transition from Avatar to Avatar India, which all our seniors from US, they were telling us for a long time. You should have a society so that you can get most of these ethical issues and other things sorted out over time. And also, and again, a small thing, I find that some seniors in the academic circle who are in right places to bring in interventional nephrology into the curriculum, some of them have serious objections. So I think in some forum we should have a debate or some form of I think we'll plan.
Bala, I don't think there should be a debate on it. This has to be done in every academic program should have intervention for nephrology, because nephrologists have a different view of their patients. So there should not be any debate about it. This is the norm, and it has to be done by every program. Don't you agree with that, Dr. Agarwal?
I completely agree, Dr. Megasri. Actually, what people need to understand, we don't have to make everyone an interventionalist. We have not everyone has to do procedures, but
That's
they
true.
must understand, because when they are talking to the radiologist, to the surgeon, to anybody, they actually understand and they can explain what they need for this patient, because some of our radiologists and surgeons don't have that perspective of nephrology that we have. So at least we can tell them what we really need. So a surgeon can create a best fistula out of very small veins. It's not going to be useful for our patient. I mean, they're technically very, very good, but they need to understand what we need from them. So I think it's a good idea to be able to explain and understand and actually troubleshoot some things with the patient right in the dialysis unit. So I completely agree. There has to be education for it.
Second thing
But
also
I would also agree with that. And again, I don't need them to know everything, just the most common things. And I'll give you a good example. We have a lot of patients who come up with crashing and they enter the ICU and they get a temporary dialysis catheter. You are surprised that the reasons don't know the tip is stupid. They're putting the SVC and the catheter is not working.
You are cutting off, Adrian.
Your voice. Yeah, your net is, I think, weak. So your voice is getting cracked.
Okay, can you hear me now?
Yeah.
Yes.
Yeah.
So I was talking about how patients come to the ICU crashing and a temporary dialysis catheter is placed by the ICU residents, and the catheter tip is not where it's supposed to be. And they say we can't dialyze the patient, and they keep changing the catheter without knowing that the length is not appropriate because they go high in the neck. So this is just an nugget of what I'm saying. You should have education. You should have education. You know everything about interventional nephrology.
The other thing also is, when you take the renal population, if you put this whole load on interventional radiology or vascular surgeon, they don't have time for this because they have other things to do. So we as a nephrologist doing these procedures, at least we can provide the basic care. If you don't want to be an aggressive interventionalist, you can at least give salvage critical situations like in the night going and change catheters or whatever it is. And it is beneficial for the patient because IR don't have time because they have to do lots of other long procedures as well because so there's load on the IR people.
And also, see, there is people have a grouse that nephrologists and specialists don't go to smaller centers, and if they are not empowered with all this, techniques to do all this, they will never go because they won't have support of IR and other specialists in smaller towns. So if you only train them, so this is another way of making remote area people get access to nephrology.
Exactly.
I think We all understand, that is why we are in this group, but we'll have to somehow convey this to the others also. I think
there will be a debate as to what should the minimum standard of interventional nephrology knowledge which the nephrologist should be proficient with.
Right.
That will be the only debate really, what should the minimum standard, not as if there should be knowledge of interventional nephrology or not. You see, in Northern America, the endovascular procedure is considered as interventional nephrology. In Southern America, it's the surgical part and ultrasonography which is considered as interventional nephrology. But if we consider Indian situation, then we need to have both the things, that is endovascular procedures plus surgical part also. So there can be debate on this part only, not on the whether there should be curriculum of interventional nephrology or not. This is my opinion.
Right, I second that.